Elder abuse is a pressing issue in Australia with profound health and social implications for older adults, placing a substantial burden on healthcare systems. Elder abuse is defined as any act within a relationship of trust that results in harm to an older person. In Australia, 1 in 6 older individuals experience some form of abuse every year. Yet living free from violence is a fundamental human right, and domestic abuse is an unacceptable violation that can constitute a criminal offence per the Domestic and Family Violence Act 2012. Elder abuse has many forms such as physical, psychological, sexual, neglect, and financial abuse, with psychological abuse being the most prominent, encompassing 73% of cases, followed by financial abuse at 63%. The Human Rights Act 2019 aims to prevent elder abuse through recognition, protection, and promotion of human rights in Queensland. As elder abuse is usually caused by a family member or friend, often elders find it difficult to confront issues. The Powers of Attorney Act 1998 further complicates this, as the powers are given to family members which authorises a person to make particular decisions and do particular other things for another person. While this law is useful for managing the assets of elderly persons who is unable to care for themselves, it also provides the unfortunate opportunity for family members to take advantage. Currently, 2% of the Australian population are older than 85, and this number is predicted to almost double to 3.7 by 2058. In Queensland, there are approximately 2,700 elder abuse notifications each year, along with 1,500 inquiry calls. This number has been shown to increase each year, with 5% of these reports involving abuse allegedly perpetrated by aged care services. Still, the number of unreported cases of elder abuse in Queensland is estimated to be around 25,000, highlighting the need to improve identification systems. These high rates of abuse create an extensive burden on the social and overall well-being of the elderly community, while also posing a significant challenge to the healthcare system. Hospitals are often ill-equipped to appropriately provide care for the surge in hospitalisations and long-term health complications, such as traumatic injury, anxiety, depression, and post-traumatic stress. The increased need of services has contributed to a $21.2 billion cost to Australia's healthcare system. Still, for those who experience elder abuse, within the first year alone, there is a 300% increase in premature deaths compared to those who do not. Due to the healthcare system stress, families become primary carers for the elderly. This can continue the cycle of abuse, as the increased burden on the family can disrupt relationships, exacerbating abuse. According to the Australian Law Reform Commission and the Elder Abuse Prevention Unit, doctors, nurses, police, and other frontline professionals have current policies and protocols in place to recognise and respond to signs of elderly abuse. Paramedics are only required to document their findings during patient treatment, as there is no current protocol or policy for paramedics regarding elder abuse. However, under the Ambulance Service Act 1991, ambulance officers are entitled to take any reasonable measures to protect persons from any danger or potential danger associated with an emergency situation. Still, there is an ethical obligation for paramedics and other first-line healthcare professionals to have extensive procedures and guidelines in place when attending a case or potential case of elder abuse. In the pre-hospital setting, it is suggested a flowchart approach be implemented directly into paramedic practice to combat elder abuse, the proposed approach being the 5-step method. This model has 5 key actions: identifying the abuse, assessing the patient's overall risk, providing support and planning their immediate safety, referring to services for further support, and documenting findings. Due to many different types and complex nature of elder abuse, the 5-step method aims to be broad when identifying risk factors for abuse. While this may increase the risk of false negatives, this broad application may reduce the current rates of underreporting and elder abuse. Abuse will be identified with a questionnaire developed by combining questions from major identification programs, such as the Elder Abuse Suspicion Index and the Self-Report Measure of Psychological Abuse of Older Adults. The questionnaire with the elderly person should be completed without the presence of a carer or family member to reduce the risk of response bias. Furthermore, the paramedics will complete a separate section noting any physical indications of abuse as outlined in the flow chart. A score will then be calculated, and in conjunction with the clinical judgment, the severity of any immediate risk and potential long-term risk to the patient can be determined. The use of clinical judgment is necessary to overcome questionnaire limitations, such as patient fear of answering correctly or impairments to their mental status. By using a universal numerical score, the severity and thus urgency of the interventions can be relayed quickly to referral services or EDs, minimising the impact of limitation consultation time, a common barrier to the elder abuse reporting. The next step will be to inquire with the patient about how they best want to be supported, in which patients may elect to not escalate their complaint. This follows the principles of ACT's utilitarianism, as progressing care for one patient may not provide the same benefit to others, and instead potentially exacerbate the abuse. This section of the flowchart aims to support this notion by providing tips and suggestions to paramedics on the best way to provide emotional support for the elderly population. If consent is gained, paramedics will then be equipped with resources for patient referral. These resources will be classified by severity of abuse, time frame of abuse, and the patient's personal preferences. Outcomes of referral may vary depending on these rankings, but may include transport to a safe location, such as a police station, making appointments with social workers, or providing phone numbers to the patient to investigate in their own time. In the full CPG document, paramedics will be provided with full explanation of these services, ensuring they can adequately explain to the patient the type of support each service can provide. The final step, documentation of findings, reminds paramedics of the importance of documenting their first-hand experiences so they can be used as evidence. This step will specifically provide prompts of what to include in the electronic patient record forms to prevent liability issues. This flowchart would become an addition to the paramedic clinical practice manuals to ensure that they are easily accessible for reference when required, reducing overall cognitive load and thus maximising intervention effectiveness. Additionally, a professional development day would be run to give practitioners the opportunity to learn about the plan and apply it correctly in their practice. The goal of this strategy is to improve the identification of elder abuse in a pre-hospital setting. Given the often subtle presentation of elder abuse, providing a framework and more objective identifiers will hopefully increase paramedic confidence in reporting abuse. When addressing this issue, self-reporting is one of the greatest barriers, hence the identification of elder abuse by paramedics may overcome this. Witnessing an elderly individual's environment and organic relationship within the home would hopefully enable early identification of abuse instead of waiting for serious injury or financial distress to trigger intervention. This 5-step model is a relatively cost-effective intervention to undertake, as it focuses on identification and directs patients to pre-existing and already funded services. The primary cost for paramedics is time, and therefore this model would only be implemented in non-emergency situations. It is proposed that an opportune time to utilise this would be during long transport or ramping times. However, the most significant financial commitment would be the creation of a professional development module to roll out this new strategy and ensure competence when implementing it. Although this may be an initially substantial cost, the implementation of this plan is predicted to reduce the overall financial burden that elder abuse poses on the healthcare system.